I'm Antonio Colombo from Milano. It's a great pleasure to me to start this section dedicated to this new bioadapter. It's not really a stent, it's a bioadapter supposed to restore vessel physiology, and you will see if you get convinced, because this is a statement and we see the data. Let me show you some introductory slides. I will be short. So I do not have any conflict of interest to report. So the objective of this session is to understand how the novel transforming bioadapter scaffold can address the shortcoming of drug-eluting stent and BRS and restore vessel motion and function. It's really important to understand how this device is made. It's really an idea that has together the metallic property versus the bioresorbable property. To know the patient and lesion then can be safely and effectively treated with Dynamx Bioadaptor. And I can answer already this question to me, any lesion where you implant a stent. And to be able to approach the delivery and deployment of the Dynamx Bioadaptor with confidence, and if you know how to implant stents, you will know how to implant bioadapter. These are the traditional shortcomings of metallic stent. I think we can go very quickly. Even if you implant a stent, in the best way, you don't eliminate long-term adverse event. We really do not know exactly why you have neoatherosclerosis. So many of these hypotheses still are waiting for an answer, but the reality is that the long-term events are not eliminated. And the lead BRS technology failed to meet the DS safety efficacy in the head-to-head, and we know all the shortcomings of bioresorbable scaffold. Current bioresorbable scaffold material being inherently weaker and resulting in suboptimal acute performance. This, in simple word, is recoil. Degradation of the scaffold material causing inflammatory reaction, late acquired malapposition, and we know the problem of some late thrombosis in the BRS due to negative dismantling of the device, and lack of dynamic scaffolding of the vessel disease without ongoing lumen support. And this you will understand why we claim that this device gives sustained support despite the fact that allows positive remodeling is a little bit contradictory statement, but you will understand later on. So thank you for your attention. Let's start with the first speaker.
First speaker is going to be Johan Bennett from University of Leuven. He has, do we have the mic here? Yeah. He's going to give us a technology overview of the bioadapter. Johan has a large experience using the device. Johan, please.
Yes, good afternoon, everybody. It's a great honor to participate in this session and to give an overview on the Dynamx Bioadaptor technology. These are my disclosures. So this was basically designed to overcome the shortcomings of contemporary DES and BRS, as Dr. Colombo just pointed out to you. The bioadapter has an acute performance similar to contemporary DES, with excellent deliverability, conformability, and also implantability, with a high acute gain. There's an early uncaging at 6 months, which enables a vessel motion and functional response to return, restoring pulsatility and compliance, and increasing the blood flow volume through the coronary arteries. Later on then, there continues to be a dynamic support to the diseased vessel and returns the vessel really to normal function, with reduced arterial stresses, improved hemodynamics, supportive positive remodeling, and lesion stabilization. So it really is truly a transforming scaffold. It's composed of 3 thin 71-micron cobalt-chromium helical sinusoidal strands, here represented by the colors orange, green, and blue, which are integrated to form the transforming scaffold. These are actually connected, so I'll just point it out to you. Maybe you can see on the screen there, difficult to see, but there are basically every ring is connected to the next ring via 3 S-links, which are permanent, do not resorb. And within the ring, there are 3 uncaging elements. These are located on low-stress positions, and they create the temporary circumferential links. The bioadaptor is coated with a very thin bilayer coating. There's a top coat, which is PLGA bioresorbable, and it eludes sirolimus over 3 months. And there's a PLA bioresorbable base coat, which holds the connecting factors, elements together for the first 6 months before it resorbs. So how does this new stent bioadaptor work? As I mentioned, the acute radial strength is similar to contemporary DES. You can appreciate the IVUS there on the left-hand side when the connecting elements are still together. As the base coat resorbs at 6 months, there is uncaging due to the coronary blood flow pulsatility. It is outwards, and you get return of pulsatile function and normal vessel function thereafter. During this new information, these separated helical strands of the connecting elements become surrounded by smooth muscle, so they continue to provide a dynamic support to the vessel, which is obviously still a diseased vessel. So what data do we have to date? The first-in-man mechanistic study has been published and resulted in CE marking in 2020. There's furthermore been an imaging study in New Zealand, and the larger bioadaptor randomized controlled trial comparing the bioadaptor with the Onyx Resolute will be presented this afternoon as a late-breaking trial at 2:45. So please don't miss that. The Infinity Sweetheart randomized controlled trial is near completion. I believe 2,300 patients are enrolled. And again, that's a large trial comparing the Onyx, Resolute Onyx with the bioadaptor. Furthermore, there will be a registry starting later on this year. Looking in a bit more depth at the mechanistic first-in-man study, this was really to evaluate the safety and performance of the bioadaptor, non-randomized consecutive enrollments with imaging in cohorts at 9 and 12 months. 50 patients, relatively simple lesions. The PIs were Dr. Ferreira and Dr. Colombo at 7 international sites. The primary endpoint, or the primary safety endpoint, was TLF, target lesion failure at 6 months, and at varying time frames after that. And the primary efficacy imaging endpoint was change in mean in-device lumen area from post-procedure to 9 or 12 months, and change in mean lumen area as well. Obviously, there were other secondary endpoints which have been looked at as well, with clinical follow-up up to 3 years. Looking at the safety efficacy data, you can see straight away that it's a safe and efficacious device. There was 1 TLR, which occurred due to a protruding calcified nodule, which we realize in the field is very hard to treat. No device-related deaths. As you can see there were 3 cardiac deaths, but these were not due to the device or actually due to coronary artery disease, but due to multi-organ failure and heart failure in elderly patients. So overall, really a safe and good efficacy and safety form. Looking at late lumen loss, in a moment, first of all, acute gain was excellent, 1.63 millimeters, which really is, comparable to contemporary metallic DES, and late lumen in-segment loss at 9 to 12 months of 0.11, and then in-device late lumen loss of 0.12, with a median of 0.05, which are really very low rates of late lumen loss. And again, it would suggest good outcomes after 1 year. I would like to show you this evidence of normal restoration of normal pressure and vessel pulsatility. This is a stationary OCT performed in one of the patients in the mechanistic study. You can appreciate there the diastole and systole. In the longitudinal view, you can see the consistent changes in area on this one stationary point. And on the right-hand side, I believe you can appreciate how the struts, or the elements of the uncaging segments, they separate during systole and diastole. Overall, this reduces there's a lumen area increase of 14% during diastole, and device or bioadaptor increase of 9%, resulting in approximately 30% increase in blood flow, which of course we don't see with permanent contemporary DES. This has really demonstrated positive adaptive remodeling. The mean vessel area, the mean device or bioadaptor area increased in size due to this uncaging, but then that means the mean lumen area can stay the same, because obviously there's always a little bit of neointima formation. If you compare this to a permanent DES, such as, for example, the Zions in the Spirits 3 study, there the vessel area might increase slightly. Of course, the stent area doesn't, because it's a fixed cage device, which leads to a reduction in the mean lumen area due to neointima formation. So contemporary metallic permanent DES do not have the ability to have positive adaptive remodeling, whereas the Bioadaptor does have this potential. Finally, during cardiac cycle, the vessels, especially the LAD, are undergoing all kinds of biomechanical forces, twisting, turning, rotation, which of course we often are not aware of. Placing a cage stent in this impacts the degree of rotational options or possibilities for the vessel, and may lead to disease progression, stent failure, etc. There's evidence from this study that the Dynamx Bioadaptor restores vessel rotation, and you can look at this analysis here of IVUS imaging post and at 9 to 12 months, and we can see that the twisting angle is much larger in the uncaged segment at 9 to 12 months, really restoring vessel rotation within the LAD artery, which was looked at in this case. So in conclusion, the Bioadaptor effectively uncages the vessel to restore positive adaptive remodeling and maintain vessel lumen. It restores pulsatility and vasomotion, restores vessel compliance, vessel rotation, and allows the vessel to return towards baseline angulation. And to date, there has been excellent safety over 9, 12, 24, and also now 36 months follow-up. Thank you very much.
Thank you, Johan. That was a wonderful overview of the technology. While and Antonio is preparing for his slide presentation on the case, please feel free to ask questions as many as you can. Use the app or the platform here or the mic. In the meantime, maybe, Johan, I'll address you a question with regards to the question that also has been raised here. What about some properties, radial force, deliverability, side branch access? Can you perhaps please shortly comment on that?
Yeah, absolutely. So basically, I think the acute performance is like a current contemporary DES. Implanting it, the deliverability is excellent. So you really are using it like a contemporary DES in terms of deliverability. You have excellent gain, which of course differentiates a little bit from the biosorbal scaffolds, which we don't have that acute gain, which we now have with this device. So in terms of bifurcation, exactly, the ability to rewire to a side branch really is also very similar.
There's a question from the audience, please.
In some cases, like bifurcation cases, we need bot for the proximal part. In this case, you think this can disconnect the proximal part from the distal part in this with this scaffold, or will not affect?
That's a great question, and Dr. Santoso will be able to address that. One of his cases is actually showing how to do bifurcation with POT. So I don't know if you want to address this a little bit now, or you want to discuss this during the case. So stay tuned. We'll show the case.
I have a question regarding the mechanistic features of the Bioadaptor. So could you point out a little bit something on the sizes and length, and what about the overexpansion ability of the scaffold or Bioadaptor?
Yes, so the size is limited to between 2.5 and 3.5 over dilatation capacity, about 1 millimeter above. So. I guess down the line, perhaps it might be something to think about to increase the size portfolio, but for the moment, that's the sizes available.
All right, I think we have to move on to Antonio's presentation.
Thank you very much. I'm just going to present some cases with some angiographic and OCT follow-up. I do not have any conflict to disclose. This is the multi-vessel treatment, and The vessel is the left anterior descending. So the right coronary artery is unremarkable. The LED in this view is not particularly diseased, but in this view you see a lesion after the second diagonal, which is protected. This is not a particularly complex case. Is pre-dilated as usual with a high pressure balloon. So the preparation is exactly the same as you do when you implant a standard metallic stent. In this case, we dilated also the ostium of the diagonal with a cutting balloon, and then we verified there is a good lesion preparation, maintained patency of the diagonal branch, and then we implanted a 28 millimeter 3 millimeter in size. We routinely post-dilate as a stent, and this is an excellent result. So the key message here that the technique to implant this device is exactly the same as implanting a metallic DS. It's very important, in my opinion, to have optimal lesion preparation, because not only to have a good deployment, but if the lesion is not well dilated and somehow dissected, you will not have the basis for positive remodeling. So the key element to allow positive remodeling is to have good lesion preparation. This is the final result with step up and step down classic optimal stent implantation. This is the OCT image. We always do OCT at the end of the procedure because we will repeat OCT at the time of follow-up in order to evaluate if there is a positive remodeling. Here is unremarkable, shows good apposition, a nice lumen achievement. This is the most distal, and here you will come to the scaffold with a nice lumen, almost optimal circumference. This is a 9 months follow-up. With almost no angiographic late loss. And you will see the OCT follow-up. I don't know why we don't start. Anyway, the OCT follow-up in this case did not see any visible positive remodeling, but you really need to do a core lab, because if you've seen the values are 5–6%, so it's not easy to grasp. But the optimal result is the lumen loss 365, 359. So it's really remarkable in the smallest segment. Okay, here we go. You see that the lumen is really well maintained. Here the bifurcation, and with a good result. This is another case. It is the ostial circumflex. I don't know why we go. I don't know why this picture does not project well. It is pre-dilated with a good result, and this is a 9 months follow-up. You see there is some lumen loss at the ostium of the circumflex, which is a real problem for any stent, the ostium of the circumflex, but clinically this focal stenosis is not relevant. We see the OCT, which is more optimistic than the angiogram with a lumen that 7.03 with a lumen loss that go to 695, which is very acceptable for this type of lesion. You see, there is I would say 30% residual stenosis as the ostium of the circumflex, which is not clinically relevant. And here is the OCT with a nice result. So I think just from these anecdotal cases, the Bioadaptor showed good result at 9 months, angiographic and OCT follow-up with minimal lumen area loss in 2 significant disease scenarios, mid-LAD, left main ostial circumflex, and later this afternoon you will have real data from a prospective randomized study. Thank you for your attention.
Thank you very much, Antonio. Those were 2 beautiful cases, very nice outcome at 9 months, including OCT data. One of the questions also that I would like to submit here is, and also one of the from the audience is, what is the benefit of technology comparing to DEB, to drug-eluting balloons? Could you comment on that?
You know, the problem of drug-coated balloon, you need to know how to do angioplasty, not only stenting. With this technology, you just need to know how to do stenting.
Is the radial force of the stent staying after 6 months as when you deploy it?
Technically, after 6 months, you don't need radial force or minimal radial force because the artery is healed. And as a matter of fact, the whole concept behind bioresorbable scaffold is that after they've done the mission, they can go away. These has some radial force because it does not reabsorb completely. So it maintains some scaffolding. And this is theoretically an advantage compared to bioresorbable because even after 2 years, you still have your frame. The frame is not solid in all aspects, but in many aspects is still maintained. So it's becomes a gentle frame.
I asked a question regarding the mechanism of restenosis that we saw in your case in osteomyelitis. Do you think if you deployed a normal stent, that the absorption was same as this one?
Yeah, the problem of the ostium of the circumflex, we studied really at length in the last 20 years these issues, is not due to compression of the stent, is hyperplasia. most probably there is turbulence, there is abnormal shear stress in that area, and you have more hyperplasia than in other areas. So it's even if you place 3 stents and give an enormous radial force, you may have restenosis.
I would like to make an additional comment to the drug-eluting balloons. I very much appreciate what Antonio was saying, that you need to know how to stent. But I think what we should not forget is that this device has so many unique features, and what we have seen and learned in a mechanistic study is that you have positive adaptive remodeling. Second, you restore pulsatility. You induce phase of motion. And there is also return to vessel angulation. So there is a lot of characteristics. And in addition, you also bring back the rotational movement radially, which also has been published. So I think there's a number of features which we have not seen with drug-eluting balloons. And as far as I know, not have been reported with any other drug-eluting stent. So that's just an additional comment that I would like to make. Before we go to the next presentation, I'd like to ask Dr. Saito, what is your take on having this device in specific population of patients? Do you see any special targets? Could you comment on that, please?
Okay, it's a very important question. In general, the very easily restenotic vessel is LAD, and also the long lesion, and also the small vessels. These 3 aspects are the target, first target of this bioadapter implantation. And then we can expand easily the indication. That is my strategy, because I was PI for the trial that will be presented after this meeting. And so I did not do any, I wanted to the, like Antonio, I wanted to try the more complex lesion, but I have no experience for that. But at this moment, I have definitely the current indication is LAD or small vessels or long lesions. That will be the first one. And then, of course, I want to expand the indication for bifurcation and calcified lesions and acute myocardial infarction or everything. Thank you.
We have used this device in any lesion, so total occlusion, following rotablator, following cutting balloon. The cases I presented were very simple because I wanted to go step by step into the audience. I don't want to just show off, but we have used this device in really complex lesions. As any regular stent. I want to ask Stefan a question. I think you may have more experience than me. There will be any lesion where you will be not afraid, but where you will not use this device.
Carotid arteries, maybe. I don't see actually any particular place where I would not use it. Based on the data that we have seen, it is a safe device. It's a very performant device. Late lumen loss. It offers a lot of physiological features that maybe that we don't appreciate at the beginning, but later on will be translated in clinical benefit.
In aorto-osteal lesions, would you use this device, or maybe that's a subset where you may have some concern?
Well, I can't say yes, I would, because I have not seen any data, but I don't see why not to do it. Because if you do a proper lesion preparation, I think this device offers you the benefit to do that in osteal lesions.
Yeah, I agree with you. I mean, osteal arteries stays open without a stent, so you don't need a stent to keep it open. An osteal lesion, provided the artery is healed.
But anyway, those lesions are out of the clinical trial indication.
Yeah.
For now, yes, but we'll see some more complex cases by Dr. Santoso.
Yeah.
That's the conclusion. While Dr. Santoso is trying to find, I will ask Holger if there's a question on how much can you upsize with post-dilatation.
Well, I think we just addressed this question, but however, I think that is a very specific and unique feature of the bioadapter, that you can go up to 1 millimeter, not only and a half millimeter above the original size, and it depends on the platform. With the 2.5 and 3.0, you can go according to the IFU to 4. And also for the 3.5, you can go up to the 4.5 millimeter. And this is, I think, very important to know, because as we just discussed, that we have, of course, also the broad stenotic and bifurcation lesion, and we want to go for the pod. And therefore, we need, of course, this the possibility of sizing up the scaffold.
Yeah, but I think 1 millimeter is more than enough. Unless someone made the mistake and opens the wrong stent, you don't.
I just addressed the stenosis in the left main, for example, which needs maybe 1 millimeter.
Dr. Santoso, please.
Okay, thank you so much for the opportunity and the honor to speak here in this forum. I must admit that I may dream years ahead of time, but given the unique features of this Dynamx, I do believe that the real future is to use this in patients with complex anatomy. Let me share you some of my cases. This is a patient who has double bifurcation stenosis involving the left main and left main D1 bifurcation. Both made in a 111, as shown here, and both bifurcation showed diminished flow reserve, as indicated by suboptimal QFR. And of course, we treated this with Dynamx, 3 Dynamx put in the circ, diagonal, left main, covering the circ ostium as well as the diagonal ostium. And we followed the usual procedures, kissing balloon dilatation, spot report, and so on. And we obtained excellent results, as shown here, with normalizations of functional analysis as indicated by the QFR. And this is the 9-month follow-up. You see here that the result is excellent. QFR on all branches were still preserved. So for bifurcation, this is a complex situation. Bifurcation, we do believe this is a good stent because side branch access is good, side branch opening is good, and the stent, the Dynamx tends to preserve the angle. So we know that the preservation of angle is associated with less MACE and also restenosis. This is another case, which I do believe also a challenging case. Heavily calcified LED stenosis, elderly patients, 88, chronic kidney disease. LED is heavily calcified with multiple stenosis in the proximal and mid segment. There is a patent stent in the mid LDD and diffusely diseased distal LDD with a sluggish flow. We treated the distal LDD with TEB, and then we have to do proper lesion preparations with atherectomy using orbital atherectomy. Calcium score was 3. Then, of course, we need to prove that the lesion was already well prepared. So we did the high pressure balloon dilatation. There is no waste anymore. And look at the in panel B, even though the patient has long segmental calcifications, Dynamx has excellent trackability to navigate across this calcified segment. And then we can fully deploy the device, obtain excellent result. Contrast utilization was only 14 cc. So I do believe that this is also another challenging case, but a good indication for Dynamx, because we know if we encounter difficulty in advancing our stent, there will be stent scaling, polymer disruption, and so on, and this can be associated with worse short and long-term outcome. And this is just to show the IFUS findings after orbital atherectomy and also balloon dilatations. You will appreciate here presence of heavy calcifications and napkin ring, also calcifications, and stent was well expanded, well exposed, and concentric. And this, in my mind, assures that we can expect, of course, we have to prove it at the angio follow-up, but we don't have that because stent is just introduced recently in my hospital. So well opposed, well concentric. This is another interesting case, long CTO. You see here, patient has very, very long CTO, and on the right, you see stop frame images of the OCT images showing here patchy calcifications, dissection here and there after balloon dilatations. And then you may be interested to see how easy is the delivery of this long Dynamx Bioadaptor, very long, 2.5 by 38, 3 by 38, to cover the whole lesions. So just two long stents in this long segmental CTO, and we obtain excellent result as shown there. And this is the final result as depicted on the OCT. Excellent result. And this is a subframe images. You see here in panel 4, overlapped stent. We try to minimize the overlapping zone in order to maximize the effect of this technology. So both stents were well opposed and well expanded, and there was also no edge dissection. We also know that in chronic total occlusion, there is often a negative vessel remodeling, and long term we can get late restenosis or even malposition. But with this, because of positive vessel remodeling and also other good features like, for example, normalization, so pulsatility and so on, we expect that the ultimate result will also be very good. Other very good indications, in my opinion, humble opinion, is for treating young patients. We all know that despite the use of current generation DES, adverse effect still accrue at a rate of 2 to 5% per annum without a plateau. And you see here that this is a young gentleman of 35 years old with one vessel disease, but very long lesion, the LAD, strong family history. We treated this with Dynamx. You see here the easy delivery shown in the panel B, and the lesion covered was 60 mm. And we also know that in LAD there's often the rotation and torsion and so on, and we expect that with this stent we can prevent this or minimize this, and thereby minimize fractures or restenosis long term. And this is just to show after peridial. Minimal calcifications, balloon-induced dissection, so lesion was already properly prepared. And this is the final result, no dissection, well opposed, well expanded stents. And long term, we know that Dynamx will allow positive adaptive remodeling. So for young patients, this will preserve the lumen. And this is also very good. Pulsatility is preserved. Normal vessel motion will be preserved. And it also allows rotational motion. So thereby we expect that restenosis rate will be lessened, or MACE at least will be lessened. So this is just the summary. Implantation is same as DES procedures. Overlapping should be as minimal as possible to maximize the benefits of this Dynamx. Set brand access, as mentioned before, is excellent. Can be opened using a 3.0 millimeter balloon while maintaining the integrity of the dynamics. Radial strength is similar to best in class of TES with post-procedural acute gain, 1.63 mm, and no acute recoil. Thank you so much.
Thank you, Dr. Santoso. This is you actually addressed a lot of the questions that were raised here in your talk. Age, young patients. It's the premise of this device that can address all of that. Contribute to vasomotor function, positive adaptive remodeling, and of course we've seen the case of CTO. I want to ask Dr. Saito, as a CTO expert, what do you see this in a CTO case? What would be the benefit? Because CTO is usually associated with negative remodeling.
Yes, in CTO, because a lot of atherosclerosis, it is something like caged. So after to open the chronic total occlusion, if we place a stent, that is another caging. So maybe it will some effect, or make some effect, bad effect to the long-term result. So if we take this scaffold, maybe it can do positive adaptive remodeling. So the long-term result will be nice. And also, I want to ask what kind of stenting technique you took for the bifurcation?
In my case,
yes,
DK crush technique.
DK crush.
DK crush, because I love DK crush.
Okay.
I was involved in many of the DK crush studies.
So,
PI was Professor Chen Xiaolang from Nanjing.
Yeah.
And we found out that this is, in our humble opinion, the best technique for true bifurcation stenosis, either a left main or non-left main. So we have very good result with TK crush technique for.
So you didn't have any difficulty.
Stenosis. Even in simple non-true bifurcation stenosis. So in this particular case, double bifurcation, but yet excellent result.
Thank you, Dr. Santoso. As we run towards the end of our session, and Dr. Colombo will give us the final remarks, I would like to ask him one more question. I'm sure we're going to have a provocative answer. When it should not be used?
When you don't plan to implant a stent. But, the final remarks, I don't want to repeat what to me, I would like to conclude with a question, and you don't answer, but you take it home for thinking. If you really confirm what we have said here, positive remodeling, pulsatility, and I hope we will confirm, we will know later on in the day, do we still have a need to develop a bioresorbable scaffold? Don't answer. Go home with the question. Thank you very much.